Hello, welcome back to lecture number 9, Congenital Heart Disease, in the series Introduction to Cardiology. I'm Joseph Alpert, and I'm going to give you a brief review of congenital heart disease. I'm an adult cardiologist, so I only get to see these diseases when the pediatric specialists who really focus on this form of heart disease have either missed the diagnosis in childhood, or the patient lived in an environment where they didn't get to see a pediatric cardiologist and consequently arrived at adult life with the disease. Or we see patients who've had operative correction of congenital heart disease but continue to have some problems because of the disease. I'm not going to do an exhaustive review of this. There are huge textbooks written on this, just this one area, but I'm going to give you a quick feel for congenital heart disease, particularly the ones that we see in adults. Again, very briefly, let's review the anatomy. Remember, the left ventricle pumps out the aorta, out the aortic valve into the aorta. Circulation passes around through the tissues of the body, comes back through the large veins to the right atrium, passes into the right ventricle, out the pulmonary artery, out into the pulmonary artery, back to the left atrium, back to the left ventricle. So you can imagine there are all kinds of problems that can occur in this very complex structure. There can be holes in the heart. There can be obstructions to outflow. For example, the valves are misshapen. You can even have the ventricle switched so that the left ventricle is pumping to the pulmonary arteries and the right ventricle is pumping to the aorta. These are all problems that occur in embryonic life, that is, in the development of the fetus. And often they're the result of either infections that occurred during pregnancy or drugs that were taken during pregnancy, or of course, hereditary. Congenital heart disease is the result of an abnormal development of the heart in some fashion. It occurs in embryonic life. It may be the result of an embryonic infection, for example, with a virus, or it may be, of course, a hereditary factor. There are a number of different forms of congenital heart disease. Most of these are identified by the pediatric cardiologist and are cared for early in an individual's life. Some individuals are discovered for the first time as adults, but nevertheless, that's usually thought of as somehow a failing for the patient to get the diagnosis made early on, and this can be the result of, for example, poor health care early in life. The patients are cared for by pediatric cardiologists, often in conjunction with adult cardiologists in special clinics that are geared exactly to the long-term follow-up of these individuals, most of whom have minimal disability following successful correction. There is a group, the group with cyanotic congenital heart disease, however, that continue to have problems. So there are a number of different forms of congenital heart disease. One is the obstructive form. For example, one of the valves is stuck, and we're going to talk a little bit about that. We already mentioned that in aortic stenosis, that the bicuspid aortic valve can become stuck so that instead of having a 3-leaflet aortic valve, you only have a 2-leaflet valve. That can become stenotic or stuck in midlife. We'll talk more about that when we talk about valvular heart disease in one of the subsequent lectures. There can be other obstructions. For example, the pulmonic valve can be misshapen, so there's stenosis in the pulmonic valve, putting an extra workload on the right ventricle. So those are obstructive lesions. You can also have holes in the heart. For example, instead of there being a clear wall between the two atria, the right and left atrium, you can have a hole there. For example, that's called an atrial septal defect. Septum is the wall between the two atria. You can have a hole in the wall between the right ventricle and the left ventricle. That's a ventricular septal defect. So there are diseases with holes in the heart that lead to increased blood flow to one of the ventricles. We'll talk more about that in a moment. There are congenital heart disease lesions that occur that actually decrease pulmonary blood flow. Often these are a complication of one of the lesions with a hole in the heart, that is the atrial septal defect or the ventricular septal defect, leading to increased blood flow in the heart. This stimulates increased resistance in the lung, and eventually the blood flow reverses. Instead of going from right to left. It goes from left to right. Patients are often cyanotic and blue. That's a severe complication of congenital heart disease, so-called cyanotic congenital heart disease. Sometimes individuals are actually born with cyanotic congenital heart disease. That requires urgent surgery in early childhood. So here you see listed all of the lesions that can occur. You'll notice that they're broken down into acyanotic, that is where the patient is pink, and cyanotic, that is where the patient is blue. You can see on the left-hand side in the acyanotic group, the atrial septal defect, the hole in the atrial septum, ventricular septal defect, hole in the ventricular septum, patent ductus arteriosus. Remember, that's the connection between the pulmonary artery and the aorta that enables blood flow during fetal life to go from the right to the left side because the lungs are not working. And then you can have a special form in which there's a ventricular septal defect and an atrial septal defect known as the AV canal. And then you see the obstructive lesions, coarctation of the aorta, that's a marked narrowing in the aorta, aortic stenosis and pulmonic stenosis. And when we look at the cyanotic lesions, there's something called tetralogy of Fallot. That's 4 different lesions, usually a ventricular septal defect, pulmonic stenosis, and some rearrangement in the anatomy of the right ventricle and the aorta. Tricuspid atresia means that the tricuspid valve is missing. That is usually associated with an ASD, so that the blood doesn't get into the right ventricle, but shunts across the defect into the left ventricle, or left atrium, and then into the left ventricle. And then there are a variety of rarer forms in the final column, transposition of the great arteries, where, as I said before, the aorta comes off of the right ventricle and the pulmonary artery comes off the left ventricle, and a number of lesser common things, truncus arteriosus. These are quite rare, but they're worth just mentioning as complex congenital heart disease that's almost always corrected in childhood, because otherwise they would be fatal in early childhood. All right, so let's start by talking about obstructive lesions. These are lesions that impair the forward blood flow out of one of the ventricles. There are 3 common ones: pulmonic or pulmonary stenosis, in which the pulmonary valve is abnormally formed, and consequently the right ventricle is usually hypertrophied. It has a much bigger workload, and often the blood flow into the lungs is reduced. If this is very severe, it has to be dealt with in very early childhood, often with a balloon catheter that dilates up the pulmonic valve. Later, the valve may need to be replaced if it scars down a lot. The same thing can happen to the aortic valve. It can be born too small, and again, this leads to marked decrease in the blood flow into the whole body, and again, often requires a balloon catheter opening of the aortic valve in early life. And again, often down the road, you need to replace that valve as it scars down. Coarctation of the aorta is an obstruction that occurs in the aorta, where the aorta is markedly narrowed in one place, and again causes decreased blood flow to the lower extremities and to the abdominal organs, and consequently one has to open that, sometimes with a balloon catheter treatment, sometimes with surgery. We're going to talk about these in a little more detail. Let's talk about pulmonary stenosis. As I mentioned before, the right ventricle has to hypertrophy, has to get bigger and thicker because it's facing a big increase in its afterload, in its work. This is can lead, of course, eventually to right ventricular failure. Often the pressure is quite low in the lung and the blood flow is quite low in the lung. And you may even see in early life or later life, you may actually see right ventricular failure with edema, with swelling of the abdomen and the legs. Again, this lesion creates a very nice loud murmur, so it's very frequently picked up in childhood and taken care of. If it's mild, it's just followed. If it's severe, a balloon catheter is put in and expanded and opens the pulmonic valve. It makes a murmur like the one with aortic stenosis. You have turbulence during systole, during the contraction of the right ventricle, and you hear shoo, 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 shoo over the pulmonic valve. Aortic stenosis, similarly, is a lesion that affects the left ventricle. Left ventricle also hypertrophies, gets thicker because it has to push harder to get the blood out into the aorta. Can also be associated with decreased cardiac output, decreased blood flow, and even needs operation or a balloon opening of the valve in very early postnatal life. That is, soon after the baby is born. If the aortic stenosis is very severe, it has to be opened by a balloon catheter or the infant won't survive. Again, it produces a systolic murmur. Each time the ventricle squeezes, you hear zoop, 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 as the turbulent blood flow passes through the stenotic aortic valve. Coarctation of the aorta is an interesting one because it's often missed. The coarctation occurs just after the arch of the aorta and consequently leads to increased blood pressure just behind it, so that there's increased blood pressure in the arteries of the arms and the arteries of the head. And there's decreased blood pressure in the legs. So there's, and also, of course, a characteristic murmur. So this may be missed by the doctors because we usually take the blood pressure on the arm. So the blood pressure might be a little elevated, but often you don't take the blood pressure in little kids, and they can have fairly normal development. I've even seen patients get into teenage years or even older when suddenly the heart began to have trouble keeping up with this increased workload. Patients may have been a little short of breath, they may have been a little fatigued, or they may be without symptoms, but it was picked up, as I'm going to show you in a moment, by a characteristic finding on the X-ray. The treatment is either balloon opening of the narrowing or operation in which the stenotic or narrowed segment is removed and a graft is placed in there. This lesion is often associated with a systolic murmur heard best over the spine. Why? Because the aorta runs along the spine after it follows the arch, and consequently, you may just hear a nondescript little systolic murmur in the front of the heart, whereas when you listen in the back of the heart over the chest, you may hear a louder murmur. The clue is that you have nice bounding pulses in the arms and almost no pulse in the legs. And you say, how come? I can feel a bounding pulse in the arms, I can't feel it in the legs. And then often a chest X-ray gives you the answer. This is one of the correctable forms of high blood pressure. Most patients with high blood pressure don't have correctable forms, but this is one of them. And interestingly enough, even after correction, there's a tendency for the patient to develop high blood pressure that needs drugs to be taken care of. As I said before, it's due to a congenital narrowing in the aorta, which sometimes slips past the pediatricians, and we see these patients in adult life when they end up with hypertension. Now, here is the finding that often is most embarrassing to the cardiologist. Maybe you've seen a patient because they had a little hypertension and you've been asked they're going to have a hernia repair or some minor surgery, and you've been asked to clear them. Yes, their heart's okay, they'll withstand the operation. And then in the preoperative chest X-ray, the radiologist calls up with a great big laugh and says, "Hey, did you guys know your patient has coarctation of the aorta?" How does the radiologist know that? Because when there's coarctation of the aorta, there's large number of collateral or reserve blood vessels that open up. Some of these are underneath each rib. And what they do is cause, you can see this little notching, this little cavity on the underside of the rib. That's a characteristic of the collateral blood vessels. It's picked up on the chest X-ray, and if you hadn't thought the patient had coarctation, it's rather embarrassing that the radiologist gets to make the diagnosis. If you thought coarctation might be there and you order the chest X-ray, that's okay. But there's a significant number of these folks, usually without severe coarctation, who slip through into adult life. If the coarctation is very severe, it's almost always picked up in the pediatric period of time. So now we're going to deal with lesions where there's a hole in the heart. These lesions are usually associated with so-called left to right shunting of blood. That is, blood which is oxygenated from the left side of the heart ends up on the right side. How does that happen? Let's take atrial septal defect that I'm going to speak about in much greater length as an example. So think about this. We're talking about diastole, that is, the heart is filling. The mitral valve is open, the tricuspid valve is open, blood is flowing allegedly into each ventricle. Oh, but there's a hole in the septum. Well, it turns out because the left ventricle is a little thicker than the right ventricle, it's a little harder to fill the left ventricle than the right ventricle. So in diastole, when all the valves are open, some of the red blood from the left atrium shunts across the defect in the atrial septum and into the right ventricle. One of the ways we diagnose it is we find there's too much oxygenated blood in a sample taken from the right ventricle. And often as much as couple of liters a minute may shunt across the left atrial, from the left atrial area into the right atrial area through the defect and lead to marked increase in the amount of blood that the right ventricle has to pump. In a ventricular septal defect, the same thing happens. Left ventricular pressure is much higher than right ventricular pressure. When the left ventricle squeezes and the right ventricle squeeze together, the pressure is higher in the left ventricle, so red blood shunts over into the right ventricle. With a patent ductus arteriosus, that's the connection between aorta and pulmonary artery from embryonic life. It's supposed to close down, but it doesn't close down. Aortic pressure is higher than pulmonary artery pressure, so throughout systole and diastole, there's red blood shunting into the pulmonary artery. You can see in each of these conditions, extra red blood is arriving in the pulmonary circuit. In ASD and VSD, it's arriving in the ventricle, the atria and the ventricle, and in PDA, it's arriving at the level of the aorta or the pulmonary artery. And what this means is there's increased pulmonary blood flow, and if this goes on for a period of time, you can have increased pulmonary resistance, severe pulmonary hypertension, and the shunt can actually reverse and go right to left with blue blood ending up in the arterial circulation. Patients have blue lips. They're markedly disabled, often because they're not getting normal oxygenation of the red blood in their arterial circulation. So let's talk for a few minutes about atrial septal defect. It's the commonest lesion that slips through pediatric years and into adult life. It usually requires closure. These days, closure is sometimes done in the catheterization laboratory with a special kind of catheter that puts a little umbrella on the defect and closes it, although occasionally if it's large, it requires surgery. In many instances, it's already been corrected in childhood, and there are some few minor problems that can occur later on in life, some arrhythmias and so forth, but most of these patients do perfectly well and lead normal life expectancies if the defect has been closed. If the defect isn't closed, as I mentioned before, the increased pulmonary blood flow can lead to pulmonary hypertension and eventually right ventricular failure, cyanosis, all kinds of things that markedly disable the patient. The hole is in the atrial septum. In an embryonic life, often there's a hole there because you want to shunt blood from right, oxygenated blood from the placenta from right to left, but that hole is supposed to close in very early life after the baby is born. Now, you can see here from this diagram what happens to the heart. You get an enlarged right ventricle because there's left to right shunting. Remember we talked about that, the reason, because the right ventricle is a little more flexible compared to the left ventricle. So some of the red blood to the left atrium ends up in the right ventricle. And the result is that there's very much higher oxygenation in the right ventricle and the pulmonary artery than normally would be there. Because normally, remember, the blood coming back to the right ventricle and to the right atrium is the blood that's had its oxygen removed in the capillary phase and passed in the veins up to the right atrium and right ventricle. One of the findings, if the patient goes on to severe pulmonary hypertension, in other words, the lesion is not fixed, one of the lesions that occurs, of course, that makes the diagnosis very easy is what you see here in this picture. This is known as clubbing. It's abnormal rounding of the fingernails. This is a very advanced example. And by the way, if you look, the fingernails are not the normal color. They're not the normal pink color. They're a darker color. And that's because you have blue blood in the arterial circulation. The pulmonary hypertension has become so severe that now, instead of the red blood shunting across into the right atrium and down into the right ventricle. In fact, blue blood is shunting across the septum into the left atrium and the left ventricle and being pumped out in the aorta. This is commonly known as Eisenmenger syndrome. It's because of severe increase in pulmonary vascular resistance from long-standing uncorrected shunting. It occurs more commonly with ventricular septal defect when higher pressures are seen in the right ventricle than occur in atrial septal defect. Nevertheless, this is a very dreaded complication of congenital heart disease. And just here again, so you see here's a little diagram of the heart, just to tell you what the findings are in a patient with atrial septal defect, why it's so subtle. There's often a small systolic murmur from the pulmonic valve, but nowhere near as remarkable as with pulmonic stenosis. You may actually, by putting your hand on the chest, feel the right ventricle, which you normally wouldn't feel in somebody. And the second heart sound is wide and stays wide. Now remember, with respiration, we talked about this early on when we talked about the normal cardiac exam. The second heart sound, splitting, moves with respiration. It gets wider during inspiration and narrower during expiration. Let me show you an example. It's bum-ba-dum, bum-ba-dum. That's in inspiration, and in expiration it's bum-ba-dum, bum-ba-dum, bum-ba-dum. So it gets narrower. What happens in atrial septal defect, because the right ventricle is overfilled, that movement of the splitting of the second heart sound doesn't occur. So you hear lump-ba-dum, lump-ba-dum, lump-ba-dum. You never hear that sound narrowing. And then there's findings on the electrocardiogram and, of course, on the echo that confirm your diagnosis. But those findings are pretty subtle, and particularly in a little child where the heart's going butta, 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 it's very easy to miss that so-called fixed splitting. So here we see a little diagram, again, of one of the lesions that can increase the pulmonary blood flow, for example, ASD. And you can see it accounts for 7-8% of congenital heart disease, which is the largest fraction. It's quite common as a discovered lesion in adults, whereas usually the VSD, because it creates a loud systolic murmur, is usually picked up in childhood. Interestingly enough, VSD can spontaneously close during childhood because of some hypertrophy of the septum. So often pediatricians will follow smaller VSDs. They don't have to be closed. Larger VSDs, of course, create a large pulmonary blood flow and do require closure. It turns out that ASD is a little more common in males than in females. And as you see, about 7 to 10% of congenital heart disease is an atrial septal defect. There are several forms of atrial septal defect depending upon where in the septum the hole occurs. The common one is called an ostium secundum. It's the one that's right over the foramen ovale. That's the little opening in atrial life that never closes or doesn't close completely. Or can be actually a failure of the atrial septum to develop normally. It's right in the center of the atrial septum, and I'm going to show you a picture of it. And here is an operative picture. You can see the surgeon's instruments to the left, and you can see we're looking at the atrial septum, and it's quite clear that you're looking at a hole. And what you're seeing on the other side is the left atrium. So you can see here's a defect. This is right in the area where the foramen ovale would have been. It's also much larger. So this was a failure of the atrial septum to develop normally. And here's the operative picture. Usually a little piece of pericardium, that is the lining around the heart, is taken, or you can use a Dacron or a Teflon patch, and the defect is closed. So this is a successful closure of an atrial septal defect. This actually looks, the heart looks reasonably large, although this is a magnified picture, but I'll bet this was not in a tiny infant. This was probably in an adolescent or possibly an adult. We're going to spend a little less time on the other lesions, but ventricular septal defect is the commonest lesion in childhood, but becomes much less common in adult life for a couple of reasons. First of all, as I mentioned before, the ventricular septum often enlarges and closes the defect spontaneously. And secondly, because the murmur is loud and easily heard in childhood, often it's repaired either with a catheter patch that's put in or with surgery. So the ventricular septal defect ends up in adult life to be much less common than it is in childhood. Number 2 in childhood is ASD, which becomes the most common in adult life because it can be missed because the findings are subtle. Again, you have increased pulmonary blood flow because during systole, the left ventricle is pushing red blood into the right ventricle that goes out in the pulmonary circulation. Again, the most dreaded complication is marked increase in pulmonary vascular resistance, the Eisenmenger syndrome, in which the patient is cyanotic, they're blue, they have decreased cardiac output, they are markedly disabled. Rarely they will survive to late middle life. Usually complications occur that cause death sometime in the 40s or 50s. The patent ductus arteriosus is the third increased blood flow, pulmonary blood flow lesion. Again, the ductus arteriosus is used in embryonic life. It's supposed to close at the time of birth. If it fails to close and stays open, then again, aortic pressure being higher than pulmonary artery pressure results in a left to right shunt, that is red blood into the pulmonary artery, markedly increasing pulmonary blood flow, and also, by the way, increasing pulmonary pressure because aortic pressure is being transmitted to the pulmonary artery. These individuals more rapidly develop Eisenmenger syndrome, that is severe pulmonary vascular disease, severe constriction in the pulmonary small vasculature that leads to pulmonary hypertension, right ventricular failure, blue blood shunting across the PDA into the aorta, and again, the Eisenmenger syndrome, marked disability, and early mortality. This murmur, a murmur associated with a PDA, is one of the most interesting ones in cardiology. Why? Because aortic pressure is always higher than pulmonary pressure. It's higher during systole and it's higher during diastole. So that means you have shunt flow both during systole and diastole, and turbulent flow in the pulmonary artery. So when you listen along the left upper border of the sternum here, what do you hear? You hear a continuous murmur that's a little louder in systole. It's a murmur that's very, very distinctive. When you hear it, you know immediately what you're dealing with. You're dealing with a continuous flow, both in systole and diastole, continuous flow of blood flow, red blood from the aorta into the pulmonary artery. This is closed, by the way, with an operation where you don't need the heart-lung machine. Why? Because you're not getting inside the heart. You're just tying off and dividing and separating the two halves of the patent ductus arteriosus. It was the first congenital heart lesion corrected by surgery because, of course, it was corrected before the heart-lung machine was available. And again, as I mentioned, the hemodynamics of it are both increased flow and increased pressure in the pulmonary circuit that can lead to severe pulmonary vascular disease. But fortunately, the characteristic murmur means it's usually picked up in childhood and corrected with a fairly simple cardiovascular operation that does not require the heart-lung machine. And again, I mentioned the findings. You're going to hear a continuous murmur. The patient may have bounding peripheral pulses because there's a runoff from the aorta into the pulmonary artery. In a sense, there's a decrease in resistance in the aorta, and consequently, this can lead to a very marked, brisk pulse. There's a widened pulse pressure because of that when you take the blood pressure. So there's a number of findings, and again, it's almost always picked up in childhood because of these findings, and it is corrected in childhood. Treatment of patent ductus arteriosus consists of interrupting the ductus. This can be done with a catheter with a little plug over a wire, or it can require operative treatment, particularly if it's big and it looks like it's going to be more complicated. It can be closed with a surgical procedure where one opens the chest and ties it off and interrupts it, cutting it after it's been tied off on both sides. These days, most of these are closed in the catheterization laboratory, but a small number are a little more complex and require surgical intervention. The final form of congenital heart disease, the cyanotic form, the ones with the ventricles switched and the aorta or pulmonary artery switched and so forth, are very complex. They are seen immediately in childhood because the baby is blue, the baby is cyanotic. They always require urgent surgical intervention. And usually what we see in adult life is not a cyanotic patient, but what we see is somebody who's already had one or multiple surgical procedures. They're very complex. We actually don't even know yet what the full natural history of these lesions are going to be, because they've only been operated on for 30 or 40 years. And so the full life expectancy of what happens after repair of so-called transposition of the great arteries, where the pulmonary artery and the aorta are switched on the two ventricles, is not fully known. And also a number of different operations have been done. So we don't know exactly what's the long-term outcome with operation A versus B. Again, these individuals are always followed by pediatric cardiologists, usually alongside an adult cardiologist who specializes in congenital heart disease in the adult. So these folks often fall into the category of partially repaired or palliated congenital heart disease because you can't completely change around the anatomy, which is so abnormal. That's different from the ASDs, the VSDs, pulmonic stenosis, and aortic stenosis. All of those previous ones, the patients can get to near normal life or normal life expectancy and normal activity. These lesions, the ones with cyanotic forms, are much more complicated, and often the operations don't completely change the environment the patients live on with significant disability. Well, in conclusion, I've given you a very quick look at congenital heart disease. As I said in the beginning, this is a very complex area that's actually the purview of a group of cardiologists, the pediatric cardiologists, who, again, often in conjunction with adult cardiologists, continue to follow these patients for their whole life, particularly where there are residual defects, as I just mentioned in the patient with cyanotic congenital heart disease. There's excellent catheter and surgical treatment for these patients. They all have very specific findings on physical exam and EKGs and echoes. I didn't go into this in great detail because it's a whole area of itself, but suffice it to say that with careful thought and examination, the adult cardiologist can usually identify these lesions based on the patient's history and the physical findings. And of course, this is followed up with a number of imaging tests. Echo, CT, or MRI give a beautiful map of the lesion, often which the surgeons want ahead of time to look at before they go in. And the results of surgical intervention or catheter intervention are very, very good for the vast majority of patients, with the exception of the individuals with cyanotic congenital heart disease, who often continue to have disability and problems. But the good news is that most individuals with congenital heart disease actually lead long and productive lives with minimal disability. Why? Because they've had the defect closed often in childhood. There's not pulmonary vascular disease. They don't turn blue. They function very well. Some even are competitive athletes. The residual problems are often in the patient with the complex lesions that lead to cyanosis at birth. As we talked about, the transpositions where the aorta and pulmonary artery are reversed. These individuals have a number of palliative operations, and they often have residual disability. Fortunately, they're a very small group. The majority of patients with congenital heart disease either have the obstructive lesions, pulmonic stenosis and aortic stenosis, or the holes in the heart, the ASD, the VSD. Usually these do extremely well with our current therapy, and often they don't need cardiac surgery. Often the defects can be closed with catheter devices. So it's a very good time for congenital heart disease, with the exception of the people who had cyanotic congenital heart disease. They often require considerable follow-up and care. And as I mentioned before, it's usually coordinated care between the pediatric cardiologist and the adult cardiologist.